You're live.
Good afternoon, everybody. Thank you for joining us for this webinar of the FREM section of the European Society of Intensive Care Medicine, discussing today the micronutrients in the ICU. Where do we stand? With Angelique de Man from the Netherlands and William Manzanares from Montevideo. And I'm Michael Cazar, the chair of the ESICM FREM section. I'm very happy to have the opportunity to organize this. Our specialty group, the Metabolism, Nutrition, Rehabilitation section, is focusing more and more on micronutrients. Some years ago, we did the Vital Trace survey. Many of you did participate in Europe and beyond, focusing on surveying how you measure and how you provide micronutrients to your patients. We had over 300 ICUs and colleagues responding. And we observed that, in fact, many of you don't give micronutrients routinely at all as an additional supplement. And then quite a lot do provide more than half, in fact, combined vitamins, combined trace elements, and then additional doses of thiamine, vitamin B complex, folic acid, and so on. And also vitamin C. 20% of the colleagues do provide this routinely to their patients. As you can see in the lower part of the slide, we tend to start separated infusions of vitamins and trace elements in our patients within the first week. Day after day, more of us do provide them to the patients if the enteral nutrition is insufficient. But there is a lot of variation, which is very logical because there's not so much data on what to provide to whom and when. Many members of the FREM working group of the FREM section also contributed to the ESPEN micronutrient guidelines, which were directed by Mette Berger, the former chair of our section of metabolism and nutrition. And I think these guidelines are very interesting. They provide a very structured background. Also, Angelique contributed to them, overseeing all these vitamins. And also, very importantly, at the start of the guidelines, trying to make a strict separation, and this is something that Mette Berger insisted on, between complementing, which is in fact providing the daily minimal requirements of micronutrients to our patients, and then repletion, it is giving doses aimed at restoring the normal status in patients where we guess that we know how much of a deficit we see. And then supplementation, this is giving additional doses because we think there are increased losses or there are more important deficits, and then pharmacological doses of micronutrients as a therapy. So in much higher doses than needed just to restore the normal levels. And I think this is what we talk about in the different studies of high-dose vitamin C supplementation that will be discussed by Angelique. So I think it's important to separate these different aspects. And so now I'm very happy in the next 60 minutes together with you to discuss first with Dr. de Man the story of the vitamin C, where we all know that the physiological, the mechanistical data was very promising in many different conditions, trauma, burns, particularly in animals, and certainly when given prior to injury, vitamin C appeared to have very strong effect on inflammation and outcome, and also in some early studies it did. But as you all know, the last studies were not really as expected, and this is what Angelique is going to discuss. Is there still a place of vitamin C in some patients at some time point based on the data we have today? But of course, micronutrients are much more than vitamin C, and that's why we're very happy that we have Professor William Manzanares from Montevideo, Uruguay, who will discuss many other vitamin-based interventions in a concise overview. Both will spend some 20 minutes discussing this, and then the three of us will discuss together what does this mean for clinical practice? And of course, we will also answer the questions that you will have during this short webinar. The questions will be collected, will be sent to me, and we will discuss them in the last 20 minutes of the webinar. So before handing the microphone to Angelique, I would like to thank all members of the previous MEN section, now FREM section, and our particular past chairs, of course. Last of them was, before me, Mette Berger. For everything established over the last years, I would like to thank the European Society for organizing all this, organizing the novel nutrition pathway, which was really a lot of fun to organize and to experience, and also for having us doing this webinar. And with this, I will give first a shout out to our Leuven Nutrition Pathway Fellows, because I know they're all following. And thereby, I will now introduce Dr. Angelique de Man, from UMC Amsterdam, intensivist with a special focus in the research on nutrition and particularly micronutrients and vitamin C. So Angelique, the floor is yours. Thank you.
Thank you, Michael, for your kind introduction. First, I would like to mention as conflicts of interest the funding we received from the Netherlands Organization for Health Research and Development for our VITACA trial investigating vitamin C post-cardiac arrest. Many of you will know vitamin C mostly from the age of exploration, when many sailors developed scurvy, and it was known as the scourge of the seas. And almost 50% of a crew could be lost to scurvy. And many human beings could develop scurvy because somewhere during the evolution, we developed a mutation in the GULO enzyme, and animal species lost the ability to synthesize vitamin C. So because there were many fruits and vegetables available, it was not necessary to synthesize vitamin C, and animal species were able to survive without vitamin C synthesis. And here you can see this is the step in the synthesis pathway which is missing in human beings, but also in guinea pigs. And we define scurvy as vitamin C levels below 11 micromole per liter, and hypovitaminosis C is defined as plasma levels below 23. And you would think scurvy is just something from the age of exploration, but scurvy can also be encountered nowadays, mostly in patients who use too much alcohol or have a mental illness with very purposeful dietary restrictions. But also the singer-songwriter James Blunt developed symptoms of scurvy because he went on an all-meat diet. However, we also frequently can encounter decreased vitamin C levels in our critically ill patients. And as you can see here in this graphic, that patients after cardiac arrest, with cardiogenic shock, after stroke, but especially also septic patients have decreased levels of vitamin C. And even more, patients with multiple organ failure have enormously decreased vitamin C levels. And this is probably caused by increased consumption of vitamin C because of the increased oxidative stress, because of the underlying illness. This can lead to increased use of the antioxidants, so decreased levels of, for example, vitamin C. And this increased oxidative stress can lead to cell damage, tissue damage, and organ damage. So the increased oxidative stress causes tissue damage because the reactive oxygen species can attack healthy cells and lead to their death. And vitamin C as an antioxidant, which donates electrons, could be a good solution for these sick patients. And vitamin C has multiple mechanisms by which it can improve outcome in patients. It can decrease oxidative stress and inflammation. It can improve endothelial function. It can increase the synthesis of vasopressor, and it can also improve endothelial function. So it is a very promising micronutrient to treat our critically ill patients. And even more, in animal studies, there were signs that vitamin C could also attenuate infarction size and also reduce atrial fibrillation after, for example, cardiac surgery. It could reduce intubation time and improve diuresis. So it was very promising in several preclinical studies. And what is important to mention is that the antioxidative effects of vitamin C increase with increasing dose. So higher doses could lead to a more antioxidative effect. And we know from our own study, our own pharmacokinetic study in critically ill patients, that at least 2 grams of intravenously administered vitamin C is necessary in critically ill patients just to normalize plasma levels. So for repletion, as Michael already explained. However, the vitamin C levels are quite difficult to interpret in our patients because we know that with increasing inflammation in all patients, vitamin C levels will decrease. And this could be because of increased consumption or increased losses, but it's also partly explained by redistribution or dilution because of administration of fluids. So it's partly, these patients will have a real deficiency, but a part of these patients will just have an apparent deficiency. Because, for example, in patients after elective surgery, about 24 to 48 hours after surgery, plasma levels will be decreased, but without administration of any vitamin C, these plasma levels will also normalize within 5 to 7 days. And so therefore it might be interesting not just to look at plasma levels, but maybe we should look at other matrices to measure vitamin C. For example, we could perform intracellular measurements in erythrocytes or leukocytes. And recently there was this very interesting study by Anitra Carr et al. And she showed that in septic patients, the ascorbate levels in the neutrophils was exactly the same as in healthy persons. Although in these same patients, the plasma levels in the septic patients were enormously decreased. And in these septic patients, the concentrations in the erythrocytes were also decreased, but not as much as the plasma levels. So it could be that either erythrocytes or leukocytes could be a more reliable matrix to measure micronutrients in. So this was what I just described, normal vitamin C concentrations in neutrophils and decreased levels in erythrocytes, but higher compared to plasma. And what is another important thing, we don't know what would be the exact duration to give vitamin C, because reactive oxygen species can be damaging, but they also have an important physiological role. So we also need reactive oxygen species for our homeostasis and normal cellular function. So maybe it's not a good idea to give vitamin C too long. So therefore, there are at this moment multiple clinical studies which have been performed to investigate repletion or supplementation of vitamin C. And this was a very nice overview from Paul Young in a recent number of intensive care medicine. And well, he described this timeline when for the first time scurvy has been described, when James Lind conducted the first randomized controlled trial with vitamin C, and when vitamin C was isolated. And for us, with regard to critical care, it's very interesting that in 2014, there was the first pilot study of vitamin C. And the most important study with regard to vitamin C, which actually started the whole discussion about vitamin C, was the Palmeric trial in 2017. And as you all know, he showed an enormous decrease in mortality in his retrospective before-after study in 94 patients. So here you can see a picture of the Battle of the Oranges in Ivrea in Italy, which is a yearly event at Carnival. However, we have our own Battle of the Oranges in the Critical Care Society, because the study of Palmeric started an enormous discussion about the potential benefit of vitamin C. This study was followed by the Citrus Ali study of Barry Fowler, who did not show an effect on his primary endpoint, but did show an enormous effect on mortality. However, the vitamin study could not show any beneficial effect of the Palmeric cocktail of hydrocortisone, ascorbic acid, and thiamine. And this was followed by a network meta-analysis, which showed that there might be a beneficial effect of high-dose vitamin C. So this led to the LOVIT trial, and expectations were high for the LOVIT trial because this was the largest RCT with vitamin C in 872 patients. And it was performed exactly according to plan, and patients received 50 milligram per kilogram of body weight every 6 hours, so more or less 16 grams of vitamin C per day during 4 days. And unexpectedly, the mortality was increased in the vitamin C group. There were no differences in the safety outcomes. However, this was very unexpectedly. So the primary outcome, a combination endpoint of death, but also persistent organ dysfunction, was higher in the intravenous vitamin C group compared to the placebo group. So the LOVIT trial is a very important trial for the vitamin C research. It had a robust design. The trial was performed as planned, and it was very accurately performed with randomization via a web-based system, quadruple blinding, complete follow-up of the outcome data, and the trial results were reported according to the predefined protocol and statistical analysis plan. However, there were also several limitations. 8 patients were excluded after randomization, and 1 patient withdrew consent. However, the number of events was so high that this is not, it's not likely that this could explain the results. In addition, there was no information regarding specific pathogens and the appropriateness of antimicrobial therapy. There was no information to ascertain the presence of RDS at baseline, and there were also several imbalances in the baseline characteristics, which and actually the patients in the vitamin C group were sicker compared to the control group. Furthermore, patients were excluded if they were more than 24 hours in the ICU. However, 13.3% of the patients already spent a mean of 49 hours in other hospitals. So vitamin C was investigated as a routine supplement, not as a resuscitative adjunct. And also vitamin C was administered as ascorbic acid, so with a low pH of 5.0, and it was administered for 4 days, and we can always debate what is the appropriate duration of vitamin C, and stopping can cause rebound effects, as was shown by Harry Hemingway. So more or less at the same time, the discussion of the benefit of vitamin C was even more inflamed by the discussion about the reliability of the data of the studies of Paul Merrick. So his hospital felt the need to contact the medical journal because they were concerned about the reliability of his data. So this is of course very worrisome, although Paul Merrick is to be commended for being able to draw so much attention to vitamin C, which is of course a very interesting topic. After the LOVIT trial, actually at the same New England Journal of Medicine number, at the same time, this meta-analysis was published, already including the LOVIT trial. And the results of this meta-analysis were actually a bit surprising. It did show a beneficial effect of vitamin C on early mortality, as you can see here, but it did not show a beneficial effect and more point estimate pointing to harm for longer, for 90-day mortality. So the authors did not have a good explanation for these results, and they thought it could be that it was because of the huge number of trials, including several very small trials and single-center trials, which might have led to other results regarding early mortality compared to the 90-day mortality, which were low risk of bias studies. So it could be that this was the explanation for these results. They found no credible subgroup effects related to vitamin C dose, different populations, or different co-interventions. So this is mostly regarding vitamin C in sepsis, but at the same time, there are several interesting results with regard to prevention of atrial fibrillation in cardiac surgery patients. Vitamin C seems to be beneficial to prevent atrial fibrillation. And it also is promising for traumatic patients, as was shown by Mette Berger, and also in burn patients. And recently we published this meta-analysis showing that vitamin C may improve left ventricular ejection fraction. And furthermore, there are also several meta-analyses of Harry Hemingway showing a shortening of length of stay in the ICU, and also shortening of mechanical ventilation in critically ill patients. So there are quite some differential results in all these studies. And recently there was also a very interesting study showing a beneficial effect of extremely high dose vitamin C in sheep. So this will lead to new trials. One of the things all these trials have in common that they all use one dose for all the patients. So every patient receives the same dose for the same duration. And it is the question whether this is appropriate. So where do we stand now? In conclusion, I think at this moment, vitamin C as a high dose monotherapy is currently not recommended. It's actually the same recommendation as was published by the ESPEN guidelines as described by Singer in 2019, antioxidants as high dose monotherapy cannot be recommended. Effect modification due to underlying pathogen and organ failure profiles, such as RDS, has not been excluded. At this moment, I think intravenous vitamin C should only be given in research context with close monitoring. I think we should keep an open mind for other indications besides sepsis, as I shortly mentioned. And what's even more important, I think we should also investigate that not just more one-size-fits-all studies, but personalized therapy based on patients' illness severity, level of inflammation and oxidative stress capacity, and maybe also intracellular instead of plasma levels. And these levels should be rapidly available and not after 2 weeks, which is mostly the case. And furthermore, I would like to mention that a repletion dose during critical illness, which is 2 to 3 grams intravenously administered per day, should be differentiated from the supplementation doses and the pharmacological doses as has been used in these trials. So this is still recommended, as we recently described in the ASPEN guidelines for micronutrients. At this moment, there are several very interesting trials going on. Low with COVID, low with RDS, CZ, REMAP-CAP, and also the high dose, extremely high dose vitamin C, and investigations in patients with burns and post-cardiac arrest. And I think it is very nice and interesting that the results of the REMAP-CAP will follow soon, because the results of the LOVIT trial were so unexpectedly that it's nice that we have another large trial investigating the same patient population. The CZ trial for early administration of vitamin C, they administer vitamin C within 6 hours of sepsis. This study is ongoing, is also very interesting. Different effects in COVID-19, ARDS, or pneumonia patients. These results will follow in the next years. I think we should look at longer duration of treatment, maybe different biochemical compositions, such as base salts instead of acid formulations. And I think we should investigate personalized medicine based on rapidly available plasma and or intracellular measurements. This was what I wanted to tell you today, so I will now give the word back to Michael.
Thank you very much, Angelique. That was really wonderful. The story, the way we have seen it build up over the years, summarized in 20 minutes. Congratulations. And I think, once again, a story where the larger RCTs really helped us in becoming maybe even more modest in going from the promising mechanistic results, smaller trials, to finally the larger RCTs evaluating the true effect of these interventions. But as you say, indeed, luckily there are still many very interesting and different trials in different contexts going on. So hopefully we can provide very soon updates on these. And I suggest that we will discuss this more in detail after Professor Manzanares' talk in the remaining time. So I will be very happy now to introduce Professor William Manzanares, who is very kindly joining us from another time zone. I hope it's already morning there. I didn't check it out, William, but thanks for sharing us. You as an expert in ICU nutrition, who also aggregated quite a lot of the available data over the previous years, giving us guidance in what to do at the bedside. And so now telling us, looking beyond vitamin C, because of course we have many other vitamins that have been tested and others that have not yet been tested. Where do we stand today in the ICU? The floor is yours, William. Thanks a lot for joining us.
Good afternoon, everyone. Thank you, Michael, for inviting me. It's my great pleasure to be here with you, taking part of this exciting webinar. I have no commercial relationship relevant to the topic being presented. Upon completion of this lecture, the attendees should be able to assimilate recent research data on vitamins with practical and for safe and effective application in the ICU, identify which ICU patients will most likely benefit from supplementation of high-dose vitamins aimed to improve clinical outcomes, and finally gain an insight into the current situation of micronutrients with current evidence. So I'm going to focus on vitamin D, vitamin B1 or thiamine, and intravenous high-dose micronutrients. And finally, I want to discuss with you my point of view about future research in the field of intravenous vitamins and trace elements in the critical ill. So the first point I want to share with you is about vitamin D. As you know, vitamin D is a micronutrient and a hormone precursor with many biological functions in tissues where vitamin D receptors exist, such as the cardiovascular systems, lungs, kidney, pancreas, the gut, the immune system, muscles, and bones, where vitamin D plays a key role in calcium metabolism. Here in this picture, you can see the immunomodulatory and anti-inflammatory effects of vitamin D. Vitamin D is able to inhibit the expression of pro-inflammatory genes and thus the synthesis of pro-inflammatory cytokines, and at the same time is able to stimulate the synthesis of cathelicidins, which are a family of antimicrobial peptides with activity against bacteria, viruses, and fungus. What is already known on vitamin D status in the critical ill? Well, according to data derived from observational studies, we know that vitamin D is frequent in ICU. Vitamin D low levels are frequent in ICU patients, and vitamin D low vitamin D blood or plasma level are associated with higher overall mortality, as well as a higher incidence of acute kidney injury and a higher incidence of infectious complications. Over the last decade, several trials have evaluated the effect of high-dose vitamin D in different ICU patient populations. This is one of the most important trials published so far on vitamin D therapy in ICU patients. Almost 500 patients, ICU patients, were included. ICU patients expected to stay at ICU for at least 48 hours. The primary outcome of this study was hospital length of stay, and the intervened patients received a loading dose of 540,000 units of vitamin D3 and followed a maintenance dose of 19,000 units per month during 5 months. The analysis of the results of these studies showed that there was not any difference between both groups in the primary outcome, but interestingly enough, in the subgroup of patients with severe deficiency of vitamin D, the authors were able to find a significant reduction in hospital 28-day and 6-month mortality, as well as a reduction in CRP and procalcitonin levels. More recently, another very interesting and very elegant trial was published in New England Journal of Medicine, the Violet trial. This study included more than 1,000 patients. The intervened patients received a single enteral dose of 540,000 units of vitamin D3. And the primary outcome of this study was 90-day all-cause mortality in patients with high risk for RDS and mortality. Unfortunately, the analysis of the results showed that there was not any difference between supplemented and placebo groups regarding the primary outcome, 90-day all-cause mortality. This study is still running, I believe, the Vitalize study evaluating the effect of high-dose vitamin D3 on 28-day mortality in adult ICU patients. The estimated enrollment is 2,400 patients, adult ICU patients with anticipated ICU stay for at least 48 hours and enrolled within the first 72 hours after ICU admission. The primary outcome of this study is 28-day mortality. The intervened group received vitamin D3, a total dose of 900,000 units of vitamin D3, and followed by 90 days with a daily dose of 4,000 units per day. And I think that the study completion date will be soon, and we hope no later than March next year. In the recent COVID-19 global pandemic, vitamin D has received much attention for treating and preventing COVID-19. In this table, you can see several small trials with high risk of bias evaluating the effect of vitamin D in COVID-19 patients. And most of these trials show a reduction in systemic inflammation. However, the most important trial evaluating the relationship between vitamin D supplementation and coronavirus disease 19 was recently published in British Medical Journal. More than 6,000 patients were included into the study. There were 3 groups of individuals, 2 intervened groups, and 1 group was placebo, and the follow-up period was 6 months. Although supplemented patients showed an increase in the vitamin D levels, in 25-hydroxy vitamin D levels increases in patients supplemented with vitamin D. However, vitamin D supplementation was not associated with a reduction in risk of all-cause acute respiratory tract infection or COVID-19. 4 years ago, we conducted a systematic review and meta-analysis on vitamin D supplementation in ICU patients. And after aggregating 6 trials that reported on mortality, we were unable to find any significant effect of vitamin D supplementation on overall mortality. However, the most updated systematic review and meta-analysis that was recently published in Critical Care found that after pooling 16 trials that evaluated mortality, that reported mortality in the critical ill, vitamin D supplementation significantly reduced overall mortality in ICU patients. And moreover, the authors demonstrated that vitamin D was associated with a reduction in ICU length of stay, as well as a reduction in the duration of mechanical ventilation. And it is very interesting that those trials that supplemented vitamin D by intravenous route show a significant reduction in overall mortality in comparison to those trials that supplemented vitamin D by enteral or oral route. Regarding the pharmacokinetic and pharmacodynamic profile of vitamin D in ICU patients, I believe that both parameters have not been fully understood. It is clear that, according to the recently published meta-analysis, that the intravenous route seems to be better, as intravenous route ensures the best bioavailability for ICU patient. But however, different trials published so far show different supplementation doses, and furthermore, the best biomarker to evaluate the response to vitamin D supplementation has not been defined, as several biomarkers have been evaluated, have been tested to monitor the intervention. So what about future directions on high-dose vitamin D randomized control trials in ICU patients? Well, perhaps we should wait for the results of the Vitalize study, but I believe that more dosing studies are needed, as pharmacokinetics, pharmacodynamic profile, as I told you, is not yet fully understood. Moreover, we believe that patients with severe deficiency, and I know this is a topic of debate, patients with severe deficiency, defined as plasma levels lower than 12 nanograms per milliliter, should be included, this type of patients, in randomized control trial testing intravenous vitamin D. Perhaps it's necessary to define specific patient population and combinations with other micronutrients. Let's move on to another section, and now I would like to talk about thiamine, vitamin B1 in critically ill patients. The most important active form, biological active form of vitamin B1 is thiamine pyrophosphate, TPP, which is an essential cofactor for enzymes involved in carbohydrate metabolism and energy production. And TPP accounts for 80 to 90% of the total body content of thiamine. Regarding vitamin B1 thiamine, it's important to know that clinical syndromes related to thiamine low levels lack specificity and sensitivity. And furthermore, low thiamine levels should be suspected in patients with sepsis and septic shock, burn patients with unexplained heart failure or lactic acidosis, as well as patients with neurological disorders with previous alcoholism. As I told you, vitamin B1 as TPP, thiamine pyrophosphate, is a key cofactor in the mitochondrial aerobic respiration, as is a cofactor of enzymes, key enzymes in the glycolysis and the Krebs cycle, as you can see here. So you know that critical illness, and particularly sepsis and septic shock, is a state characterized by low plasma thiamine levels, as do not forget that septic shock means systemic inflammation, and systemic inflammation is associated with capillary leakage and hypoalbuminemia, and then low plasma thiamine levels. In patients with sepsis and septic shock, as well as patients undergoing cardiac surgery, thiamine status has been evaluated. And it is important that you notice here that the lower the thiamine levels in patients with sepsis and septic shock, the lower the thiamine levels, the higher the levels of lactates. This is a retrospective study that was published 3 years ago, when those patients that were supplemented with intravenous thiamine within the first 24 hours after ICU admission were matched with patients that didn't receive vitamin B1. And as you can see here, those supplemented patients with thiamine improves lactate clearance, as well as those patients supplemented with thiamine improved survival. This is a randomized control trials, an American study from Boston. The principal investigator is Donino. The author supplemented thiamine monotherapy in patients with sepsis and septic shock, a daily dose of 400 milligrams of thiamine for 7 days or until hospital discharge. And it is important that you notice here that thiamine administration was associated with an improved survival in those patients with thiamine low levels that received very high dose thiamine monotherapy. And the post hoc analysis of this trial demonstrated that thiamine may exhibit parenteral thiamine may exhibit a renal protection effect, decreasing the levels of creatinine, as well as parenteral thiamine may reduce the progression to continuous renal replacement therapies, and finally protect against cytopathic hypoxia. This is another small randomized trial on thiamine on vasopressor requirement in patients with sepsis and septic shock. And this is a small trial, insufficiently powered trial, but the authors demonstrated a significant reduction in 24 hours lactate in these patients, as well as a higher reduction in 24 hours vasopressor dependency index. So to conclude this part regarding thiamine as metabolic resuscitation in patients with sepsis and septic shock, it is clear that thiamine shows a good safety profile. So far, no robust results support routine thiamine supplementation in patients with sepsis or septic shock. There are several differences in the recent randomized control trial concerning the time of therapy as well as the sepsis phenotype. So we believe that more research is needed, and it is needed to define the optimal timing, the optimal dosage, as well as the different the sepsis phenotype in which thiamine may be effective. Angelique was talking about the cocktail medic, the HAT therapy in critically ill patients. And since the first before-after study published in Chest 5 years ago with promising and controversial results, different randomized control trials have evaluated the cocktail medic in different ICU patient population, but particularly in patients with sepsis and septic shock. This combination of thiamine, vitamin C, and hydrocortisone is based on that, thiamine and vitamin C act via overlapping pathways. So this over the last year, great interest has been put into this strategy. I'd like to share with you 3 trials on HAT therapy, on exploring the effect of the cocktail medic in different ICU patient populations. This is the vitamins trial. This was a negative trial that evaluated the cocktail medic, and the primary outcome of this study was the duration, the duration of sepsis and free of vasopressor up to day 7. And the results, the study was negative, no difference between both groups. The intervene and control group was identified. This is another trial on testing the HAT therapy. The primary outcome of the ACTS trial was the change in the SOFA score between enrollment and 72 hours, but there was not difference in SOFA score between both groups. And finally, this is the VITAS trial. 500 patients were finally included into the study. This trial was stopped early for administrative reasons, but this was another negative trial regarding the primary outcome. So this is the human antioxidant micronutrient network. You know that different micronutrients have antioxidant properties, either directly or indirectly. And there are several physiological interactions between trace elements and antioxidant in this antioxidant network. So supplementing very high dose micronutrients can imbalance this delicate network and potentially cause harm to ICU patients. So according to this, at this stage, it's not a clear argument in favor of very high dose intravenous micronutrient, a single strategy in the critical ill. But furthermore, there are no definitive antioxidant cocktail for ICU patients, and we need to know and we need to define the best combination, the best dose, and the best timing for ICU patients. However, we know that there are several validated micronutrient interventions in the ICU. For example, major burns patients, the repletion of selenium, copper, and zinc is a recommended practice for major burns, and the duration of repletion depends on the burn surface. Or in major surgery, for example, with a high output intestinal fistula, or the repletion of zinc is a recommended practice. Or in patients after gastrointestinal tract surgery, according to the remaining length of intestine, intravenous multi-trace elements and vitamins should be provided. Or in patients with acute kidney injury, vitamins B, C, copper, and zinc, particularly in those patients under continuous renal replacement therapies. So, we are arriving at the end of this presentation, but before, I'd like to share with you these issues that I believe need to be considered for future research on antioxidant, trace element, and vitamins in the critical ill. For example, regarding the intervention, single or combined, I believe that future trials should avoid single micronutrient as intervention. Or for example, if the problem is the choice of primary outcome, I believe that mortality may be affected by too many factors, and perhaps in future trials, mortality should not be the primary outcome. And maybe it's necessary to explore functional outcomes as primary outcomes. And maybe this is an essential point. And concerning the choice of biomarkers, different trials have evaluated biomarkers to monitor intervention, micronutrient blood levels, CRP or PCT, or specific biomarkers evaluating the pharmacokinetic or pharmacodynamic profile. But it is true, and just a comment, that CRP levels should be always included, should be always determined for a correct interpretation of micronutrient blood levels in patients with systemic inflammation. So, to conclude, ICU patients exhibit low micronutrient blood levels, which is associated with poor clinical outcomes. Recent trial testing intravenous high-dose micronutrients has monotherapy, such as thiamine, vitamin C, or vitamin D, or in combination, failed to demonstrate clinical benefits. Parenteral very high-dose single micronutrient as pharmaconutrient strategy cannot be advocated at this stage in sepsis or any other critical condition. Future trials need to integrate relevant clinical outcomes with physiology, pharmacokinetic issues, and specific biomarkers to identify and monitor interventions in critical care. That was what I wanted to share with you. Thank you so much for your attention.
Thank you very much, William. I think that the two talks together really gave us an update of what we know and what we don't know today. Many promising new strategies to test, I believe. As you both suggested, also more targeted, more personalized, but all to be evaluated in future RCTs, because in fact, there where we have positive signals, quite often it is in smaller RCTs with less patient-centered or more surrogate outcomes. So, yeah, as you both said, and as also the conclusion by Paul Young regarding vitamin C, not to be applied today at the bedside. But what about the basic provision of parenteral micronutrients to our patients that are not yet receiving enteral nutrition? Because I think we all know that we don't have any guidance from RCTs there. As you might know, we, for example, in Leuven, we do provide the basic low dose intravenous vitamins and micronutrients to all patients almost from the start of ICU stay until they are on what we call full enteral nutrition, just in the idea, hoping to not to cause harm. First of all, maybe what do you do, Angelique? Do you provide
we also provide both vitamins and trace elements during the first 5 days. So Cernifit and Supliven for 5 days in all our patients who are staying more than 24 hours.
And you, William?
Yes, over the first week after ICU admission, we provided trace elements and vitamins by parenteral route. Okay, yeah.
So in fact, we all three do this while we all know that, in fact, yeah, we don't have evidence. Do you think this is something that should be tested, or maybe not in a yes/no version, but rather in a differential dose RCT? Or is it just something that we will keep on doing, although it has its own cost? I mean, in Belgium, it's charged to the patient, so it's some money that they have to pay themselves. What do you think, William? Should we test this practice that we all three do one day in RCT?
Concerning the measure of trace elements or vitamins, we were unable to determine plasma or blood levels of trace elements or vitamins here in Uruguay, unfortunately.
Yeah, we also cannot rely on measurements, because first they come weeks after ICU discharge, and also we don't really know whether they reflect the true status. That's something a comment I had regarding the CRP, the idea of including CRP in novel RCTs to differentiate responders and non-responders for multivitamin interventions is tempting, but on the other hand, CRP remains a very indirect parameter. Catherine Ingels from our group studied CRP and inflammation on blood samples from the EPANIC RCT published not so long ago. We observed, and so she observed, that in fact the relation with inflammation was quite complex. And something that I always found striking regarding CRP was that in fact in the early insulin studies, the intervention arm doing better had lower CRPs. And so we thought, yeah, there's a reflection of inflammation being attenuated. But then later on in the late versus early trials, the panic study that we did, in fact, the better arm was the arm with a high CRP, showing that in fact, maybe we can more easily push the CRP in one or the other direction than we think. So it's maybe not such a robust parameter to evaluate inflammation and then identify who will be better responders to antioxidant interventions. I don't know what you think about this concern of my side.
Well, I think the association between micronutrients and CRP is highly variable, so it's really unreliable, and therefore I think it's a problem that we try to give the same dose to everyone, and that we should investigate more in having a more reliable estimation of the actual tissue status of our patients, because they will vary quite enormously in all our patients, because the patients are so different. And I think we should stop trying to give one size fits all to everybody. Yeah. And investigate in better estimation with, for example, the intracellular levels. And we should go back to the basis and just first measure what's going on.
Yeah, as a proof of concept, because then, of course, later on, you want your data to be translatable into clinical practice, useful for people all over the world practicing ICU. So, of course, they won't have tissue levels. But I understand what you see. First, trying to understand what happens, and then trying to have clinical guidance on who are these patients. What do you think, William, about this?
But one question, do you agree that it is necessary to measure to determine CRP levels for a correct interpretation of vitamin or trace elements levels, if we have the possibility to measure vitamin D or trace elements? Do you agree or not?
It's a question for me? Yeah.
Yes, for you or for Michael, as CRP is a parameter to measure systemic inflammation. Yeah.
Yeah, I think it is in any way helpful, as long as we do not have any other opportunities. So I think at this moment it's helpful because we now do not have the possibilities to measure other things than plasma levels, and even the plasma levels we have to wait for 2 weeks, at least in our hospital, and I think in most hospitals in the Netherlands. So it's at this moment the only thing we have. But still, in our patients, they can have a combination of a real deficiency because of real losses, but also redistribution. So it remains really difficult to interpret.
Yeah, okay. And perhaps it is possible to extrapolate CRP levels to plasma vitamins or trace elements levels. If I have high levels of CRP, for example, higher than 150, I can suppose that vitamins or trace elements are lower in ICU patients, but we haven't the chance to measure trace elements and vitamins here in my country.
Mm-hmm.
Yeah, and still, even with CRP, well, I was a co-author of the ESPN guidelines, and clearly all the experts in the panel, particularly also the more fundamental experts focused on micronutrients, yeah, of course, you have to integrate it, but we still have to admit that even CRP as guidance for these micronutrient therapies isn't really validated today. So in fact, it makes us feel better because we don't like to be driving blind or sailing blind. So we have something to look at. But if we are really honest, we know that we don't have an RCT or any other proof that really CRP corrected management of vitamins or trace elements is more effective or more likely to provoke benefit than a blind or nothing at all. Without being cynical, but I think it's a problem because it's certainly something to investigate and to validate in a differential group approach, which will require even more patients, because in nutrition, time after time, we see that the small studies are promising, the observational data is wonderful, and then when we do larger RCTs, I'm afraid that what happens is most of all that the estimate of true treatment effect becomes more exact, and very often it just, as we have seen with glutamine, with other interventions, you see that the true treatment effect is much less positive than expected over the decades before the larger trials. So I think even a CRP guided approach should in fact be first validated.
Yes, and I think Mette Berger, in one of her articles, she mentioned that maybe we can just lower the reference ranges for patients with higher CRP levels. So for the time being, I think that would maybe be the best approach for where we stand now with all our evidence. So she recommended to decrease the reference levels by 20% when CRP levels were above 50. So I think that's very practical approach for where we stand now with our evidence.
Yeah. But still, in fact, requiring validation.
Yeah, definitely.
But unfortunately, I would have liked to have this discussion much longer. I'm just looking at the side, seeing that we have no additional questions from the audience, but we have our guidance that we are closing or coming close to the end of this webinar. So we didn't discuss as long as hoped, but we did have a very nice overview, I think, and also with a lot of new perspectives for future research. As William mentioned, focused on more patient-centered outcomes, certainly going beyond 28-day mortality, rather like 90-day landmark mortality, including also functional outcome, where are the patients? And also something we didn't discuss is, in fact, there are these high-dose interventions less promising than we thought. There is the basic provision of micronutrients that we all do while awaiting further evidence. But then also another question that we will have to address another day, I think, is we always focus on high doses in the early phase, but perhaps there's much more to do in this small group of patients staying beyond day 10, beyond day 20 in the ICU with vague phenotypes of prolonged critical illness, stomatitis, skin tears, non-healing wounds, and perhaps they are the true candidates to evaluate in future research. But of course, this would need very large network studies because most of us luckily see many patients leaving earlier from the ICU. Angelique and William, I'm sorry to already have to stop the discussion here. I thank you both for the very interesting perspectives on the different vitamins. And I'm sure this discussion isn't over yet. I thank the European Society of Intensive Care Medicine for giving us the possibility to bring this this knowledge to our members. I encourage all you who like this to join us in the FREM section. Just send a mail and you'll be a member. And don't forget that we have very soon new elections for many positions in our society. So please vote as you have the possibility to vote. So with this, Angelique, William, thanks a lot and have a nice day
as
to all
well.
of you.
Yes, okay.
Thanks to you. Bye-bye.
I was happy to join. Yes, thank you. Bye.
Thank you. Bye-bye.